Okay, welcome to the experts. Welcome back from coffee break. I think we're going to get straight to it if possible. This session is it's entitled Standardization and Harmonization, and the way that the format is trying to work here is that there'll be two speakers to address, sort of summarize the evidence base or the lack of evidence base, should we say, and then have some comments or questions from the experts, and then two audience-based questions for participation. So just to say as well, the first disclaimer, because Prof. Povo and myself have been asked to talk about the real-world omalizumab use, and we've identified some key questions here. The first focusing on special populations, then looking at starting dose and initial duration of therapy, and then Prof. Povo will take over for me to focus on non-responders and responders in terms of dose adjustments and duration of therapy. The first disclaimer I would like to say, being from South Africa, is I will use any omalizumab you give me. It's, as Marcus mentioned earlier on, it's very difficult to access omalizumab still for many of our patients. So in my setting, often these kinds of questions you literally will try to get for your patients whatever access you can. So to kick off straight away, we're not going to focus on the bulk of CSU data in terms of omalizumab. We just don't have time. So we've picked the key, some interesting populations that are emerging. So the first is those with angioedema. So the small sort of 5 to 10% of patients that we consider to have histaminergic or CSU-related angioedema only. Certainly from the big RCT data, there are patients with chronic urticaria, primarily wheals, that also have angioedema, and the treatment with omalizumab has been shown to decrease the number of days of week with angioedema. And in more specific trials, the exact RCT, they had a pre-specified entry criteria of having 4 or more angioedema episodes in the last 6 months, and there omalizumab at the dose of 300 milligrams every 4 weeks decreased angioedema activity scores, frequencies, quality of life, so definitely effective. And this, there's a great recent publication by Dr. Turk, and where they've summarized in a sort of question and answer some of these smaller data sets. So this table for your review is just is basically just a case of 15 cases, tabulated case series, indicating the specific group of angioedema only, and showing in all of these cases that omalizumab treatment was effective for this group. What about this other group now, which is the chronic urticarias with with inducible forms of urticaria in addition? The main thing here in chronic inducible urticarias is it's still off-label use for omalizumab, and the big RCT, so I've made a mistake on the slide, I should have said excluded patients with significant inducible urticarias. But basically there's still sort of case reports and case series, and you can see again this comes from the same paper, which has really summarized this into a lovely figure showing the good response to omalizumab treatment for the chronic inducible, so the chronic spontaneous urticarias together with inducible urticarias. And similarly to the data Carsten showed from the UCURD registry, the dominant forms there are symptomatic dermatographism, the delayed pressure urticarias, and the cold urticarias. And so there's certainly is a large body of evidence, and Marcus Mara and colleagues have put in a systematic review specifically focused on inducible urticarias. So that's in a separate and standalone from the chronic spontaneous group. So again, emerging sets of evidence there. So what about the complex medical patient and also patients and concerns that there were around malignancy? So certainly if you look at the asthma literature for omalizumab, data from post-marketing surveillance, there does not seem to be any concern about any increased risk of malignancy. And I found this recent paper was a nice small real-world study just with 32 older patients in whom they gave omalizumab treatment to, and they had a variety of comorbid medical conditions, including cardiometabolic problems, oncological problems, and or other infections, and certainly they had no additional side effects or problems. So it seems that omalizumab, the evidence suggests that it can be used in these complex medical patients with other comorbidity. And in essence, really, one paper actually said that the only contraindication really to omalizumab would be hypersensitivity to the product. Now we'll get some expert opinion on this because the database is small for this. Then we saw the introduction of studying this about children under 12. Again, it's currently only licensed for use in over 12s, but it is licensed in asthma for over 6 years, and there's definitely no additional safety signals in that group. And again, actually, if you look at what's published in the literature, you can only find this small case series or individual case reports to show that different doses can be used, and it does, again, look like it's effective, but certainly a place for much more data. So you heard MX pregnancy project, and here, if you look at the FDA has given omalizumab a pregnancy category B category. The EXPECT registry for omalizumab in asthma, which is probably where the most data for omalizumab exposure to pregnancies, had 191 pregnancy exposures with no additional adverse effects. And here you can also see this table summarizes, again, case reports or case series with 10 patients. And I thought what was interesting, because I put in here the data about 100 pregnancies from the PREG-CU study. I saw a MEC showed 280 cases, but what's interesting there is that there were only 7 with omalizumab treatment. So actually, even that study won't necessarily add to the huge, as expected, to this sort of database. So the biggest data set really remains in asthma. What about the initial starting dose? Well, it's kind of the consensus is 300 milligrams every 4 weeks for adults, and that comes on the back of really pooled analyses of all the randomized controlled trial data, which shows that the 300 is more effective than the 150 milligrams every 4 weeks. There's also now been Bernstein has a nice meta-analysis of 84 real-world studies, and really they showed that in 62% of cases, people were starting with 300 milligrams every 4 weeks. And similarly, there's another publication showing 8 out of 10 patients in the US with chronic urticaria, spontaneous urticaria, starting on the 300 milligram dose. And really, if you look at, in reverse, if you look at the responder rates, and the reason for that is 150 milligrams every 4 weeks, really the rate is somewhere between 15 and maximum 35%. So definitely less effective in actually treating wheals. And then in addition, if you look at the angioedema episodes related to that, it's also less effective. So I think there's considerable data to support this as an initial starting dose. Initial duration of therapy, this is actually a more difficult one, because when you look at studies about, looking for studies to discontinue therapy in responders, there really isn't many studies. And then actually, the reason we treat for that duration of time is really because the big RCT studies either treated for 3 or 6 months data. And if you look even at the slow responder group with the AST positivity, you'll see that the response rate still hovers around 60 days. So it's interesting to know. And then you saw data earlier showing that most people are actually being treated for 1, 2, or 4 years. So I think it's that's quite an open question that I'd like to hear from the experts on. So I think we'll stop there and hand over to Ted.